So we're very happy to bring this topic to you on National Hispanic Heritage Month. There is just so much to recognize the rich cultural influence of Hispanics and Latinos in the United States. Latinas are a diverse group of women with ancestries from over 28 countries, and almost a quarter of all births in the US are to Latinas. And as we know, while there's a very high initiation rate, 80% of Latinas in the US initiate breastfeeding, indicating that they do intend to breastfeed, only 16% are able to meet the national guidelines of 6 months of exclusive breastfeeding, suggesting that there are systemic barriers that contribute to this drop-off rates soon after birth. Today we'll be hearing about the Latino Best Start program, which examine beliefs and practices about breastfeeding among Latinos using qualitative and quantitative data. LBS partnered with faith-based community organizations and did focus groups and surveys, and also developed and implemented a first-of-its-kind leadership-based curriculum to promote breastfeeding exclusively among Latinas. So today we learn about the program, the process, the lessons learned, the rich findings from the focus group surveys and the community, and also look at the curriculum and the evaluation of this outstanding program. So I am delighted to introduce our presenter for today's session, Dr. Diana Derige. Dr. Derige is the National Director of Health Initiatives at Urban Strategies, where she leads the National Health Strategy Development, Program Implementation, and Evaluation of the organization's broad health equity agenda. She is also co-director of the Center for Latina Maternal and Family Health Research at the University of Houston. And prior to joining Urban Strategies, Diana was a program officer at the W.K. Kellogg Foundation, where she supported local investment by serving as a convener, collaborator, catalyst, and responsible for nurturing opportunities for affecting positive systemic change in our communities. Diana has been dedicated to this for over 15 years, and she has designed and managed several private philanthropic, government, and nonprofit programs. And she's concentrated on promoting public health and social equity for marginalized communities. And as we celebrate this month and the contributions of so many wonderful leaders, we are especially honored that Dr. Derige is with us today. Many of you might know that she managed the Kellogg Foundation's first food portfolio, and was our own USBC's program officer when we first got the funding from that. So Diana's visionary leadership and nudging got USBC on its equity journey. And without you, Diana, your guidance and support, we could not be where we are. Everything that you see about our coalition capacity building support and our racial equity support was started due to the funding from Kellogg Foundation, as well as Diana's leadership and guidance through this process. So we are very, very honored to have you, Diana, and I'm going to turn it over to you now. Diana, your line might be muted.
Am I on?
Yes.
Let me show my screen. Okay. Nope, cancel. Let's do this. All right, I think that's it. I think we can see it now, hopefully. So thank you, Kinkini, for the introduction. I appreciate that. It was very gracious. To all those of you on the line that I haven't spoken to in a while, it is good to have you join me in this conversation again about health equity and the role of that. I'm going to take you through this presentation, and I want to be clear that it's not going to be, I'm not going to be able to cover everything inclusive for Latinas. That is a much longer presentation, sessions as it were. So you'll forgive me if I don't do everything, and you can ask questions, and I will do the best to be able to answer them. I want to start with recognizing that our work around breastfeeding comes from this health equity, this role of health equity, and this idea of health equity, and breastfeeding being both a means and an end. And I'll come back to that in one second. But really, when we thought about breastfeeding's role, urban strategies in particular, we looked at kind of the definition in our goals for Healthy for 2020. And really, the health equity is about attainment of the highest level of health for people, right? And it's about eliminating health inequalities, which really is the difference in health that are avoidable and unfair and unjust. So when we think about breastfeeding, when I say it's a means and an end, the breastfeeding, the ends really are to reduce and eliminate health disparities, to improve maternal, child, family, and community health. But the means, I mean, is that it really does, the act of working on supporting breastfeeding, and all of you in coalitions know this, is building back those social networks that have such huge benefits for not just breastfeeding, but maternal child health and community functioning. And these are key to when we talk about improving health. And so breastfeeding, when it came to urban strategies who had never done that work before, recognized how this could be one of those tipping points, one of these moments where they could use this work to go forward. So. And all of you on the phone know this information. I don't really have to belabor it, but the benefits of breastfeeding, right? So when I present this, I present to people who don't often know. But again, we know about that exclusive breastfeeding for 6 months has been associated with reduction of asthma, ear infection, SIDS, type 2 diabetes, obesity, stroke, hypertension, and stroke and hypertension is for mothers, type 2 diabetes, breast cancer, ovarian cancer, hypertension. And for our smallest babies, the necrotizing enterocolitis. And we know from our from Melissa Barczyk's work, her original work, that if 90% of U.S. families could comply, we could save approximately $13 billion and prevent the excess of 911 infant deaths. So these are things you know already. The most recent work by Barczyk et al. Really shows the medical costs, about $3 billion, non-medical costs 1.2, death costs about 14 billion, and the total significant deaths of 30.
Diana, we lost your audio. Diana, yeah, now we can hear you.
You can hear me? Okay.
Yeah, for a minute.
Okay, sorry about that. I've got people texting me now, they can't hear me. So, okay, I will watch that. So when we look at breastfeeding for matters for all families, again, we look at the difference, 1.7 times, 1.4 for ear infection, for Hispanics, 1.5 times more likely for GI infection, 2 times more likely for necrotizing enterocolitis, 1.4 times more likely for SIDS, 1.5 times more likely for child death. So the risk is greater and has significant impacts on our communities. And so let me go to talk about, give you the universe from which I'm speaking about right now. So Latinas, as Kinkini pointed out, represent women from ancestry of about 28 countries. And for the purposes of this presentation, Latina and Hispanic are interchangeable. We choose at our organization to use the word Latina and Latino, so just know that. So don't get caught up in those kind of issues. But what I want to point out is because of that ancestry, they also come from backgrounds that are different in their immigration, migration, and colonial histories, which all have impacted their health outcomes. The stressors that they have experienced in their lifetime and the generational stressors that their families have experienced. But of the 4 million births in the US, we know about 1 in 4 are to Latinas. The birth rate is about 72 per 1,000. And Latinos account for more than half of the total US population growth from 2000 to 2014. Just a quick fact, and this is just to kind of you know, people often, when they think about Latinos, they're like, oh, they have great birth outcomes, they breastfeed all the time. We'll talk about that a little bit later. But, you know, some of the things that we do know is that Latinos are more likely to have diabetes, gestational and chronic, compared to their non-Hispanic counterparts. Now, I also put this up there to understand that when we talk about Latinos, we often talk about this aggregated data set we get, right, that represents all Latinas, right? And so Latinos are not a homogeneous group, and their health outcomes and their health practices are different. So I point out this: in 2010, the infant mortality rate for our Puerto Rican sisters was 7.1 per 1,000. And for our Mexican sisters, it was 5.1 per 1,000. The national average was 6.1 per 1,000. So we have a group that is above the national rate, and we have one that's below. Now, what we do know about Latinos in the U.S. is about 60% of them identify as Mexican or Mexican American. So when we aggregate our data, it is often overwhelmingly tilted towards Mexican health outcomes, which means that we often mask some of the issues that our other groups are facing. And it's part of the reason why disaggregation is so important, and why aggregated leads to systematic barriers in a lot of ways for Latinas. And again, Kinkini pointed out in the introduction that over 80% of Latinos breastfeed, unfortunately only 16%. So we're not talking about one or two people dropping off. We're talking about 80%, a vast majority of Latinos want to breastfeed, intend to breastfeed, start breastfeeding, and yet they just drop off. So if we're talking about this ideal population that people like to point to, like Latinos breastfeed at really high rates, if we believe that, we have to ask ourselves, and what happens? They just all can't decide that it was not for them. There's something larger happening that no longer makes it an individual choice, but there are real systematic barriers that exist. So we worked with the CDC, and we asked them to release some of the restricted data, because Hispanic subgroup data for breastfeeding in the National Immunization Survey is actually a restricted data set. You can't get it unless it's requested. It's not published. So the 2012 breast rates, we look at the breakdown that they have for Hispanic, and as you can see, we have initiation rates as high as almost 92% for our South American counterparts, and as low as almost 72% for our Puerto Rican counterparts. And then exclusive breastfeeding, again, we have a high of 17.6 for Mexican American, and as low as 14% for our Spanish Caribbean. So there is a difference, and those differences play themselves out in how Latinos receive messaging, how they get programming, and also in how Latinos are spread geographically across the country. So I put that there just to show you that there is a real difference. We know that. And even these categories were really interesting in the conversation with the researchers we worked with. It's like, what is the difference between Mexican, what's Mexican American? There's comments about acculturation in here. I'll have you know that none of that stuff can be really caught with the National Immunization Survey, but that's a longer conversation and something for not this webinar. So the Latino Best Start. So when we began this work of health equity at Kellogg, we started to look at some of the groups that have been traditionally marginalized in healthcare. And when we went to look for a national group that was talking about Latinas and breastfeeding, no one was doing that. And some of the answers from some of the larger institutions were like, we don't work with Latinas because they do that. They breastfeed. 80% of Latinas breastfeed. It's not a problem. It's who they are and in their blood. So besides that being fundamentally kind of racist, we wanted to know what would the feelings really were about Latinos and breastfeeding. So the W.K. Kellogg Foundation funded urban strategies to collect information on breastfeeding practices and beliefs, to provide information to tools to promote breastfeeding, and to move from breastfeeding initiation to real duration and exclusivity, to create models that address barriers to breastfeeding Latino communities, and to share lessons learned. And that was the whole goal around Latino Best Start. So the next model you'll see is what they went about it, and it most resembles the public health model of intervention mapping. So looking at what we're trying to accomplish, and then collecting the qualitative, quantitative data, developing a plan and a logic model, developing the curriculum, and evaluating the program. And so the focus groups, again, are our qualitative community surveys conducted by the community. Were quantitative, all this and the research The Jennifer Litt review went to curriculum development and then the evaluation of that. And urban strategies, historically, and for this project, works through community faith-based partnerships. And this was unique to breastfeeding as well, because these groups weren't traditional breastfeeding partners. They didn't do breastfeeding work, but they saw that this work was important to their mission, again, because it was serving mothers and communities and the impact it could have on supporting the health of their communities and also the immediate needs of moms and their infants. So these are community partners across the country, and there was a diverse partners chosen specifically so we could have some representation and understand. So the community conversations focus groups consisted of 27 focus groups across the country at 9 different sites. There were 3 sets of focus groups. We talked to providers, business owners, and families to kind of understand what was going on in the communities in breastfeeding. And so what we learned from the healthcare system in this way was, for the community participants, they reported unjust treatment by healthcare personnel. And this isn't key because it wasn't one person, right? It wasn't one person's story. We found this again and again, focus groups across the country. And it was key to understanding that this was a systematic barrier, that they felt that they were being treated unjust, that people were not talking to them. They were making assumptions about them, that people were not asking them their opinions about things or understanding where they come from as far as cultural nuances. And so this was key that we heard, right? And so any of us who work with the Latino community, any of these findings, you'll say, oh, yeah, that's pretty standard. But this is key to report and also to get published and also to think about when you're creating curriculum, because we don't often think about these nuances. Because if they feel treating unjust from healthcare workers, what is their response to healthcare workers then when they try to come and help them, right? And I'm using air quotes when I say help. For our healthcare workers, they believe that they understand the Latino community. Even if these healthcare workers identified as Latino, they felt that they understood. But like many of the other surveys that have been done and the research that's been done about healthcare workers, they use subtle divisions of things like us and them. We also found that healthcare workers, and we'll come back to this later, that healthcare workers had 2 different opinions about Latinos, very distinct. And it was on either end of the spectrum, and it was very interesting, and it'll play into some of the findings and the work that we did later. So healthcare workers either believe when it came to breastfeeding Latinos that the population I work with, the Latinos, breastfeed. They just do it. It's cultural. It's something they do. I don't need to talk to them. I don't need to bang the drum. They've got this. This is what they do. And then you had another group that was the Latinos I work with are poor and low-paying jobs. They're not going to breastfeed. They're just going to go to WIC and pick up formula. I don't need to talk to them. It's just going to cause a division between us. Interesting enough, so we have both spectrum. Interesting enough, we have the same outcome. Again, no one was talking to the families, right? The women or their families about breastfeeding because of these assumptions that were made, which create, again, these systematic barriers. And the individual story, the individual personal story becomes a political statement about how people are treated within the healthcare system and how people are treated as it comes to breastfeeding. So again, some things that are pretty general to working with Latino community, as we found in these community groups, in these focus groups, that food is central to defining culture. And this became really important for Kellogg when they started developing the idea of first food, right? And food and coming together and your ability to provide and nurture, food is central to defining culture for Latinos. Family gatherings are important and key to communities. Participants agree that people are connected by their country of origin. So when you say Latina or Hispanic, not everyone recognizes themselves in there. They recognize themselves by origin, right? So I'm Salvadorian, I'm Puerto Rican, I'm Mexican, I'm Mexican-American. And this idea was strong with new immigrants, but remained a value in the 2nd and 3rd generation participants. And there's a lot to be said about self-identification and the importance of it. I recognize myself as a Latina, but more specifically, I recognize myself as a Chicana, which identifies those who in the know about my political, social, and economic identity. And so those things play a role in how people see themselves and what groups they belong to. The other really key part here, and anytime you work with communities and the Latino community is important, is to understand who the family is, right? Who their influence are. And La Familia as a significant strength, even if it's not related by blood. So these families, these social networks are key to everything we do, and they don't even have to be our blood relatives. which is in contrast a lot to a lot of the programming that looks at individual behavior change and that looks at just the nuclear family. So the community survey. Now this survey was done paper to pen in communities by community lay workers. And so there's some real questions, I guess not questions. The rigor of the data is always a little bit questionable when you do community data collection. And so we're working with that. But let me tell you what we found in general. So the mothers surveyed with children aged 5 and younger. We were able to collect surveys, 786 of them. The respondents' median age was 30. The number of children was a little over 2. The place of birth, for instance, was a quarter of them said U.S. born, 70% said foreign born. And I want to point out that all of our Puerto Rican sisters on the island of Puerto Rico recognize their colonial history and report themselves as foreign born. And what language did you speak most likely at home? About close to 60% spoke Spanish, was what they spoke most at home. 11%, over about 12% English, and about 25% spoke both. Now, we're going to come back to this again, so I know I say we'll come back a lot, but I want to get to this data. Which breastfeeding method did you use? We found that exclusive breastfeeding, about 30%, but almost half of women reported mixed breastfeeding, right? Breastfeeding and formula, and about a quarter said they would do formula only. We also asked the respondents why they chose to breastfeed, right? Why they chose the feeding method they did. Actually, that was the question. And of the 745 that responded, the question that the most influential factor in women choosing how they fed their infant was mothers' belief that breastfeeding was a healthier choice. That was the most influential, and that was key in how we developed our curriculum. So the obstacles, again, we see there's racism, discrimination, lack of community support. So we didn't go through all the employer information, but it was the general employer information said, oh, breastfeeding is important. I don't know how to support that locally. I don't know how to do that. I don't know what they want. So we didn't really write all those up. But there was lack of employer support, and there was lack of community support, which we thought was very interesting because women, the Latinas we surveyed, and the families understood breastfeeding as a concept, but the where and how to support that in a community model was a little bit harder. So these are the things that came out as obstacles. So then we started developing the curriculum, and we called it Latino Best Start curriculum. And so we had to sit back and we had to think, so if most of the mothers that we were talking to understood the importance, that they knew this was a healthier choice, if national data, even though it could be flawed, says 80% initiate breastfeeding, what is going on? This isn't a normal curriculum where we can pick what people just, and it's not the Latinas or the Latino community doesn't know that breastfeeding is important. There's something deeper going on here. So when we looked at developing Latino Best Start, we looked at this rationale that the work had to be strength-based. Anybody who's worked in community knows that communities are tired of people coming in and telling them what they do wrong. So this had to be strength-based, and it had to be respective of culture and identity. It had to be grounded in values and recognize those values, right? And some will say, well, what if the values have negative effects? And we figure out the ones that have the positive effects, and we influence those, and we go down deep. It's based on a we theory, understanding the collectivism around Latino communities, that this is a journey we do together, even as a mother and a baby is an act between those two. This is a journey to go together, and this is what we have to do is support a community together. It's designed to create local champions. It's a fundamental belief from urban strategies that communities have the ability to heal themselves. So if any work that we do has to be sustained, and so local champions are key. We can't come in and say, we're going to give you something. We are going to give you something. And then when we're gone, hopefully you'll take it with you. But we're going to really build local champions in this work. It's culturally relevant and it's flexible. Again, as I pointed out earlier, we worked in community faith-based organizations. And for us, it was really important that they embrace this work. So it couldn't be a 12-hour session, an 8-hour session. It was talking to families, it was talking to mothers, and it had to be things that they could break up and fit into their health ministry and understand and work with. It was designed to be highly participatory, right? That's just good adult education. that people aren't just spoken to, that they get to participate in this, and it's leadership skill focused. How do we make people, how do we support people to be the leaders of their own lives? And so the lesson topics of Latino Best Start are values, right? What are our values as a family? What are our values as a community? Reinforcing those positive values, talking about non-positive, things that are not as positive, and how we use our values to get across them. Then we do some breastfeeding education, right? Some basic, a healthy start, a healthy life. Talk about the mechanics of breastfeeding, what really breastfeeding can do to support community health. And then the rest of it is all leadership, advocacy, making things happen, developing a plan. And you see developing the plan is a 1 and a 2. This is the role playing. This is the, how do I get this done? How do I talk to my doctor? How do I talk to my grandmother? Play it out, think of scenarios, and really work through it. Because the idea is, again, that these women's lives, these families' lives are affected every day. And we all can't have our lactation support right next to us. So we become our own advocates. And how do we do that? How do we make this real in our lives? So we worked with our community partners. We did train the trainers, and then they administered this program. And 786 Latinas took part. And the purpose of it, really, we're very clear about what the purpose was of this curriculum, was to increase health advocacy and breastfeeding knowledge and behaviors through workshops delivered by LBS partner agencies. So the idea really is to build their ability to do this. We knew with the timeline we had, we couldn't necessarily look at duration and exclusivity right away, but we wanted to be able to build people's thinking, build people's advocacy and knowledge would help them be able to get to this. And we had a pre and post test, and we found movement in the desired direction observed for every single item for which we were measuring as far as the curriculum. And they were both, those findings were both clinically significant and statistically significant. So that's a little bit about LBS. Now, you'll be able to go later to our website. The LBS information and all of its resources are free and available. So you can download them and use them as needed. You can use them to inform the programming that you do. You can use them directly as a boxed curriculum. But this is really what we found was useful. I also want to point out that we recognize that the flexibility in it, right? So that was one of the key points. And the flexibility is, it goes back to the idea that people identify with their country of origin. And so they have cultural beliefs, they have certain practices, they have even certain festivals and things they recognize. So being able to take that curriculum and make it specific to the population you're serving as much as possible is key. People need to see themselves, right, in the work that's being done. And so the recommendations came out of this were, you know, from the community survey, and then just comments during the focus groups and comments during the actual education program, was that we need healthcare workers to talk to us and work with us. We need to be respected by them. We need hospital policies that are inclusive, including linguistically appropriate services. WIC, we had comments that there are really good WICs and there are not so good WICs. And so we need to get some best practices and make them systematic throughout that system. Workplaces need to know, and this was important for Latino communities that we went to. For those business owners that wanted to participate, it's really hard. They found it really hard to say, okay, just go look at the best case, the business case for breastfeeding, just do that. They didn't really have any practical ways to use that information. And so they needed real help, and families needed that. That would have benefited them greatly. And then childcare. Many of the women we worked with were in low-paying jobs or worked multiple jobs and came from two-worker households. So childcare was key. So having childcare providers that could support breastfeeding and knew how to handle breast milk was key to being able to continue their breastfeeding experience. So that was a little bit about LBS. Now, I want to just touch on, for a few minutes, the serving Latinas and their families. So we took all our findings, and we also processed this and really looked at other things that were going on and how we could use our findings also to inform what we were doing in our larger work in maternal and child health and health equity. And so one of the things I want to point out is what happens in the context of when you don't have the information you need. So Las Dos Cosas, Bartek and Reyes, it talks about the non-exclusive breastfeeding among Latinas as commonly seen in the newborn period. The reasons behind Las Cosas is not well understood, and they include beliefs that formulas, vitamins, and adding formula is a better result for a chubbier baby, which is desirable. So this was an interesting topic, and we actually heard it in the meetings. And this mixed formula feeding was something predominant. So mixed formula feeding happened both because moms had to return to work or to school, but they also were doing the best that they could, or felt that they were doing the best that they could without having information, right? So if someone is not talking to them and not supporting them or not giving the information that they need because they make assumptions about who they are, what they can do. And Latinas fundamentally, you know, from the work that we found, had a cultural basis for this is the breastfeeding is a healthier support, but we're being inundated by commercials, as we all are, you know, social media and commercials, by formula. If formula is being pushed by their hospital, by their pediatrician, by their obstetrician, like it can't be all bad, right? And it's obviously got these things like DHA, and you guys have seen the commercials, right? There's now things moms can drink and make them healthy for the babies. There are things that babies can drink. There are things that toddlers can drink, and it's going to develop their brains. So in the absence of having information, you do the best you can, right? And so you breastfeed because it's the healthier choice, and you then add formula because it has these other things that you may not have. So really what you're doing is doubling up, right? And this works well for the formula company because if you get this Latino population, as I pointed out there, is a huge buying power. And building brand loyalty in this population is critical to their survival. So they're going to keep pushing this to this community. And when we don't have all the information we need, we do things like what's best. And so this mixed feeding, Las Dos Cosas, to me is one of the most sinister things because women are thinking, Latinas are doing what they think is best for their babies. And really it's having the opposite effects, right? We're losing the benefits for them and their babies of 6 months exclusive breastfeeding, all the health benefits that come along with it. We could very likely be reducing their breast milk production, which means they have to stop sooner anyways. So we have to think about those things. And those are those kinds of systematic things that happen that people are kind of like, well, you know, they just do that. And so we don't really dive into what's really going on. And it's a really, if you think about it, it's a real logical process to go through. Like, okay, if I know breast milk is healthier, we know this is good, and I have this understanding, but dang it, if my doctor doesn't want to push this formula, so it can't be all bad, why would they push anything bad on me? But that is a larger story. I just want to point out that, you know, if
Deanna, we lost your audio again. Deanna, we don't hear you yet. So do you want to just check the sound and see if the external microphone?
There we go.
Okay.
Yes, can you hear me now?
Yes.
Okay. Sorry about that, guys. So you will have to make up the things you missed in the middle. But here's the closing on this is we really looked at the ecological model when pursuing both maternal and child health and in breastfeeding in particular. That interpersonal, the woman sits in the middle, right? And things need to be culturally and linguistically competent for her. That she lives within an interpersonal network. So things need to be family inclusive programming. We need to include the family. And again, that's not just blood. The social institution factors that we start to normalize this. And for this particular project, the Latino Best Start, it was normalizing within churches, right? So work where you're at. And so if communities are trusting in churches, and this is where they're getting information, how do we help the pastors and the ministers of that church understand the importance of breastfeeding? And that meant using the resources that they believed and held true, right? And that was the Bible. Community factors that supports, childcare support we recognize was really key to to our population, and workplace support. And public policy. So we all live under this, all of us know this, you know, we're experiencing right now. We live under this tent of public policy. So paid family leave was critical to this population, and so were the policies around WIC. And that's really kind of where we landed with this work. We are continuously learning from this process and really trying to take what we know and make it readily available to communities. So with that, I can open it up for questions. I apologize for the audio issues, but I'm happy to answer any questions you might have.
Wonderful. Thank you, Deanna, for that fantastic presentation and for sharing how a program like LBS with its, design partnerships, strength-based curricula, built-in advocacy, and really working with key partners in the community and using the assets within the community are also needed. So we have some questions here. What specific policy issues do you suggest for WIC is one of the questions that we have.
Yeah, so some of the things around WIC was really, so the language issues and understanding the cultural nuances is really particular. So, I mean, I fall either way on this cultural competency training. I think people do it really well and people don't do it so well. And so I think knowing where our communities are coming from are really important. I think that the addition of the food basket and additional resources for nursing mothers is great. I think supporting them in what the foods they do eat and understanding, the cultural relevance around that is important as well. We have some other recommendations right on our website, so you're welcome to look at that.
Wonderful. We have Cheryl says that love your framing that we have to help. How do we support people to lead their own lives? And that is so key because sometimes we want people to lead the lives we wish them to lead. So that is so key in what you did. There was, again, lots of agreements about the desperate need for disaggregated data and analysis. So how do we advocate and make sure that that's happening? One question on how can LBS be brought to other cities in the US? So we could use the curricula, but in terms of your own focus groups and your expertise, is there any way of collaborating with Urban Strategies?
Yeah, so you can go to our website. So Urban Strategy is currently, right now, because I'm kind of on this speaking tour about our information, doesn't have any training workshops set up, but has a place for you to request them. So part of our work and part of our grant was to disseminate. So we have all of our curriculum available online, so you can download, as I pointed out, and you can also then request, is there a way for us to do a technical assistance training seminar? We can figure out both, do we have the resources, is there cost sharing involved? But the idea is to get this information out. It's not meant to be ours. And like I said, and it allows for flexibility in this. What we ask is that you respect the kind of premise that it's built on, which is this leadership and support and this kind of helping women and families. We don't use the word empower, but helping them strengthen their ability to advocate for themselves, right? If you go on that premise, we are happy to kind of support you in that work.
Oops, sorry, Diana, I was muted. I didn't realize. So yeah, we had a question about the format of the focus groups. Were they, you had discussed that they were 3 strands with the healthcare providers, the communities, and the employers. And did you utilize some of the folks from within these domains to lead the focus groups, or was it, facilitators that did that?
Yeah, we have facilitators. We have internal facilitators that did that work. So we had facilitators from each one, and they, depending on who was assembled, were either done in English or Spanish, depending on what the group was most comfortable with. Some sites actually had us do English, like they were recruited. Our community sites recruited for English focus groups, and some recruited for Spanish focus groups. So whatever the community was most comfortable with. But we did all the our community partners did all the recruiting, and our staff did the focus group leading.
Thank you. And then another question on how do you, you mentioned the deep connection that LBS had with the faith-based organizations, and how did you work with, you know, the training and other outreach with the faith-based community? If you can expand on that a little bit.
Yeah, so these are one of these lessons learned about working, knowing who your partners are, right, and knowing where they're at, and meeting people where they're at. So our community partners first had to understand, our community partners in these things were community faith-based organizations, right? Not most, some were centered out of churches, and others were just community faith-based organizations. And they had to see how this related to them, right? Like how breastfeeding related to them. And so we talked a lot about bringing community together, supporting the larger strengthening of community through health. We talked about unification, and we talked about how that was important to them. So was this a program that was just about mothers? Could fathers be involved with this too? How could their elders and in their church settings or in their congregations or community organizations be involved? So it was really helping them work through of where this fit in their work. And so we did do things with working with Bible verses, like helping our pastors embrace this, right? Because if they could if our pastors and our first ladies of their churches made this normal, then the communities would follow with them, right? These are leaders in their communities. Just like if we work with the grandmothers and the aunties, because these were the ones who were taking care of children at home, but also the ones that people went to advice for if they found these normal. So we worked in those kind of structures. So it was really about talking to the community leaders and say what would be needed. And it was really interesting to listen to some of the older women talk and be like, oh yeah, they should so do that. Or, oh, we didn't do that and this is why. I mean, women's stories are really important. Family stories are really important to understanding and supporting them.
Thank you. We have questions again and comments about, you know, the us, them, and specifically with Las Dos Cosas, and how often that it's so important to hear and validate for the mothers that they are doing the best, and then, you know, educate, because so often they with healthcare professionals, it can be disdainful towards moms, and to just have that understanding. One comment says that, you know, the us, them is used not just in the in healthcare, but this language seems to be on the rise, as we see in debates and decisions about immigration, DACA, disaster relief, and how can we intentionally address this, whether this is happening in healthcare, schools, workplaces, and in our communities. Any ideas, Deanna, for tackling the us versus them?
I have some ideas that we could talk about in depth later, but I think some of the things is we need to be, so where appropriate, so this is one of my favorite sayings, and I said this to Kinkini earlier, it's like, if you have come to help me, you are wasting your time, right? But if you've come because your liberation is bound up with mine, then let us work together. And I think that's part of it, is communities need to be able to lead their work, and they need allies, right? And allies need to know their roles in that. When they see injustice, when they see something's wrong, to say something, right? Don't always look for maybe the Latina in the room to say, why isn't there a Spanish-speaking person here? Why is that? To bring this up, why is this inappropriate? Because allies are important and needed, but they should not lead the work. I mean, I think, for instance, you know, the disaster relief that's going on right now in Puerto Rico, for instance, talks a lot about where we're at with breastfeeding there. Why wasn't there donor milk available there? What's kind of going on? Why are there so few Spanish-speaking IBCLCs, and why do our peer supports not get as, you know, aren't connected to the networks as much? Why are they seen as outsiders? So there's a lot going on there. And I think natural disasters, for instance, only intensify the inequalities that we actually see. And so this shows, you know, so people talk about breastfeeding, and NAPLC is doing a great job of breastfeeding in emergencies. And we need to recognize where our Puerto Rican sisters are, because systematically, half of the population in Puerto Rico gets C-sections. And that isn't, I would say that is not by choice, right? It is a systems issue. And so this gives us an opportunity to look at what's happening, see what's wrong, and to do work towards something better. And so those would be my opinions on that. I'm happy to discuss in more detail later.
Amen to that. That's so true, that this is just bringing to the surface what, what's happening in emergency situations in Puerto Rico is what is under the surface constantly over here.
Well, in Puerto Rico, for me, Puerto Rico is a good example, but we're also seeing things in Harvey, and we do health work. We do health work in Texas. Mixed status families are in crisis, right? We talk how important it is for women to get prenatal care. We talk about it's important to talk to. We're actually working more with our churches because they're asking us for maternal and child health, because that's where people are going, because they're scared to go anyplace else. The fear mongering is huge, and it will affect people's health, and to the larger degree it'll affect our community's health. And so we need to recognize that, and recognize that our futures, our health, are wrapped together.
Absolutely. And I wanted to, there's another question which says that can your slides on the data represented, the data, disaggregated data slides, be used by a physician here for physician pediatrician education?
Yes, the disaggregated from the immunization, we worked really hard with CDC to get that information, and our job was to help other people get to too. So, okay.
Sarah, we are getting a lot of questions about where exactly the resources for the curricula can be found. Can you see the or the Latino Best Start link, and then will you be able to post that, please? So it's not under Urban Strategies. Latino Best Start has its own web page, right? Website.
It's actually both, right? It's both and. So it should be. We've listed it on our presentation, and if people have trouble finding it, let Kinkini know, and I will get you a direct link to it. But you go on there, and then you go to resources. So all this data that we have on there, our findings, our community partners, and the curriculum itself is listed under there.
Another question again on one of our participants here works very specifically with the Salvadorian community, and she wanted to know if there were specific resources on that you knew about.
Not off the top of my head, but I would tell you to post that question on our site, and we'll send it out to our partners. I mean, part of this work is we are all working together and trying to find answers. We don't want to have to recreate the wheel for everyone. So go ahead and ask that on our site. I'll also reach out to NAPLC and see what they have, but we didn't specifically work with Salvadorian population.
Thank you. I just wanted to share again, Diana just mentioned that NAPLC is leading some of the efforts in the aftermath of Harvey and Irma and now Maria, in coordinating and getting resources out about infant and young child feeding during emergencies. And NAPLC has teamed up with Safely Fed Canada, which has collated resources. They've created a guidance for media as well. So please go to the NAPLC website, read the statement on infant feeding during disasters, sign up for it yourself. You can be an organizational or personal sign up. They have a lot of resources here again on their website in Spanish language as well as coordinating on the ground support. So if there is a sign up for folks who are still needing in post Harvey and in Florida and in Texas and other states that have been where you can sign up. If you speak Spanish, you speak English, you can do that. With our friends in Puerto Rico, we definitely need to see. So look at the Hispanic Federation has the Unidos campaign, which is doing hurricane relief for Maria victims in Puerto Rico and the Dominicans. So please look at those as well. We'll be posting the media information on our emergency preparedness learning community. So this is the USBC learning community. We've been supporting and coordinating and posting these on our social medias. Use our forums, our files. If you have other resources that we don't know about, please let us know. And if there's anyone from Naples or Stacy or Brenda, Felicia, if you want to add anything, please let us know how else we could be doing that. One other thing that I just wanted to say is that throughout this month, we've been posting a lot about birth, breastfeeding, leadership, different ways in which we can learn. And what this says is that though this is the month that we are lifting up and highlighting very intentionally, this doesn't stop with this month. Please, there's a resource sheet in the webinar page today, which has all of these different resources and groups that you can join. What we need to do is to have the same kind of intention the rest of the 11 months of the year as well. We have some archives of our, we've picked out some really good ones that you can explore. Join our learning community. Check each one of these out if you can. There's a lot of good information out here. And we will continue our discussion, but I wanted to, again, thank Deanna so much. Do you have any closing thoughts, anything that you didn't get to speak about, Deanna?
So I want to thank you again for inviting me to be part of this. I agree with Kinkini. I think this is a conversation that we continue to have, and I would encourage you, in particular, because Puerto Rico is on my mind, so the news cycle will run to something else next, right? There's always something else to catch your eye. The women and families of Puerto Rico will continue to need your help as they rebuild their island. And remember that it is a microcosm of what kind of happens in the US with structural racism, with disempowerment, colonialization. And that's what we see literally on the news when something is destroyed like that, when a health system can drop at a pin. So I want us to think about that as we work to support families and babies. And I want to continue to tell you that the road is long and the struggle is hard, but it is worth it. And I am on this journey with you. So I look forward to working with anybody who's interested. So thanks again.
Thank you so much, Deanna, again, for a terrific session. And we will continue our discussion, especially also about how we can support Puerto Rico and others and how we can be more primed for that. So please join the post-webinar breakout discussions. Again, all of the slides for today, as well as some of the resource materials, are on the website page, and now we break out for that. Stay connected with us, and we will, find ways in which we can explore how we can apply some of the learnings from today's session on. Thanks, everybody. Until next time. Goodbye.